Speaking of New Orleans, gastric acidity, peptic ulcer, and gastroesophageal reflux, pharmacology. Okay, we're switching away from the cardiovascular stuff. Yay. Something maybe, no pun intended, but something maybe a little more digestible. Um, Stuff is, I'm a little, oh, it was a try. Come on. I don't know, this stuff's interesting. The reading and references Goodman and Gilman, and I failed to put the chapter on there, but if you're going to read Goodman and Gilman, you probably have the intellect necessary to find the chapter. I think. Okay, a little bit about acid peptic diseases. These things they involve pepsin and gastric acid dysfunction. And so the key with this is despite normally being corrosive, pepsin and gastric acid don't normally cause symptoms or damage. So, these things are there to break down food, etc. But normally the stomach has defenses against that, against its own acidic environment. However, dyspepsia and/or erosive esophagitis occur when esophageal protective barriers break down, okay, and essentially mucus and things like that forming protective barriers. And the treatments that for these diseases involve one is decreasing gastric acidity. Another would be enhancing lower esophageal pressure, essentially keeping contents down from coming out into the esophagus is one way you want to treat these things. And then also stimulating esophageal motility. Under normal conditions, mucus and bicarbonate protect the gastric mucosa in the lining of the stomach. And the production of both mucus and bicarbonate is stimulated by our friends prostaglandins. Okay, and if prostaglandin production is disrupted by things like NSAIDs, then you can get things like gastric duodenal ulcers, that sort of thing can occur. It's also important to note when discussing ulcers and that sort of thing that Helicobacter pylori is an infectious agent that plays an important role in the pathogenesis of peptic acid disorders. This was a big thing. It must have been 10 years or so ago now that discovered that there's this, it's actually an infection that was a big problem with ulcers and that sort of thing. This rather simple slide just shows a picture of a stomach mucosa stained with a Nissl stain. Not going to really go over it, the transition slide. But I am going to go over gastric acid secretion. It's important to have some idea how gastric acid is treated because a lot of drugs to treat disorders of gastric acid secretion block the event. So in terms of gastric acid secretion then is a highly complicated, complex, continuous process. It's regulated by neuronal, paracrine, and endocrine signaling molecules. The neuronal molecule is mainly acetylcholine that's involved. So cholinergic drugs can be used for gastric acid disorders to a certain extent. Paracrine regulation of gastric acid secretion is by histamine. So histamine, as you remember, will, from its point of origin, can diffuse out. And then endocrine regulation is by gastrin. Gastric acid secretion is mainly controlled at the basolateral membrane of parietal cells in the gut. Okay. The receptors that are involved in causing gastric acid secretion include the muscarinic M3 receptor, which is a G-protein coupled receptor that couples to GQ. So when that receptor is activated, ultimately you're going to get intracellular calcium release, among other things. The histamine receptor, histamine H2 receptor is really important. That's a GPCR coupled to GS, and that's a target of drugs like cimetidine, that are used to decrease stomach acid. And then CCK2 receptor, which is a receptor for gastrin, which is also GPCR that's coupled to GQ. Okay. It's important to note, you can see these guys coupled to GQ or GS, so probably only logical that cyclic AMP and calcium in parietal cells of the gut regulate a proton pump that's involved in creating an acid environment in the gut. And this proton pump, you guys probably be somewhat familiar with, exchanges hydrogen and potassium ions across a parietal cell membrane. And with the proton pump, the result of the activity of the proton pump, what happens is you get an intracellular pH of 7.3, so about normal, and an intracanalicular pH, so these little canals, like things in the gut, of 0.8. So that's pretty darn acidic. Okay, and these canaliculi basically comprise a secretory network through which acid is secreted into the stomach. Okay, so this slide shows you right here. You can look at these caniculi, these little canals that are involved in the secretion of acid to the gut. And lo and behold, I stayed on Canal Street. Yahoo! Okay. In terms of the things that stimulate gastric acid secretion, a lot of that happens at the level of the head. So smell, sight, taste, and anticipation of food all activate brain areas that regulate gastric secretion, and the result of gastric acid secretion is part of the cephalic phase of gastric secretion. So briefly, the CNS structures involved in gastric acid secretion include the dorsal motor nucleus of the vagus nerve, the hypothalamus, and the solitary tract nucleus. Okay, what happens is efferent fibers from this dorsal motor nucleus, basically, probably just remember the vagus nerve. You get information coming down the vagus nerve, projects to the stomach. Okay, and so these efferent fibers synapse with ganglia of the enteric nervous system, which in the ENS, enteric nervous system, is essentially the nervous system of the gut. Okay, and so these fibers project down the vagus nerve from the dorsal motor nucleus, and then synapse on enteric nervous system neurons, and the neurotransmitter used is acetylcholine. And then it's acetylcholine from the enteric nervous system ganglia stimulates gastric acid secretion by activating those muscarinic M3 receptors on parietal cells. Okay. And in addition to stimulating gastric acid secretion directly, acetylcholine will also do this indirectly by causing the release of histamine from enterochromatin-like cells in the gut, and also causes the release of gastrin. So acetylcholine is a really big player in gastric acid secretion. This slide shows the dorsal motor nerve. So it's just essentially the point of this is just that you've got these efferent nerves coming that project down the vagus nerve, right? So there's these efferent nerves going to the gut, and then on the other side we have the sensory nerves that are shown here. Okay. The big idea is that the brain, through acetylcholine secretion, regulates gastric acid secretion. Okay. And the enterochromatin-like cells that release the histamine, they're located near the parietal cells, so close enough that the histamine can diffuse and activate parietal cells and stimulate acid secretion that way through activation of H2 receptors. Okay. A little bit more physiology before we get into the drugs. Gastrin is an important player in gastric acid secretion, and gastrin is made in G cells that are located in the fundus of the gastric antrum. Everybody know where the gastric antrum is? Did you get that pathophysiology. It's basically at the bottom of the stomach. I have a little picture of it in a second. So there's these G cells that are found there, and they make gastrin. And gastrin is involved in causing stomach acid secretion. And its release is in turn activated by things like CNS activation, local distension of the gut can cause gastrin secretion. Also, chemical components of gastric content can cause that if the gut content is acidic enough, we'll get gastrin secretion. And then histamine can also cause gastrin secretion. Okay, I have a picture showing a slide showing gastrin secretion and somatostatin secretion, which we'll go over right here in a second. Okay. In addition to gastrin, though, somatostatin is another important player in gastric acid secretion. It's the inhibitory component. So somatostatin inhibits gastric acid secretion. Somatostatin is made in B cells of the antrum, so it's made in a similar area as the G cells that make gastrin. And somatostatin is secreted when pH of the gastric lumen falls below 3. So when your stomach environment gets too acidic, somatostatin will be secreted to damp down gastrin secretion and allow for a slightly more neutral environment. And among other things, H. pylori infection decreases the production of somatostatin. So negative feedback involved in regulating gastric acid secretion is blocked when you have that H. pylori infection. And that will help contribute to ulcerative symptoms. This slide shows feeding and gastric acid secretion. Let's see, just going to go through it here with my trusty pen pointer. So, at the times of feeding, so say the smell of food, etc., that of course is going to stimulate areas of the brain that then send signals down to the gut through acetylcholine release. So you get acetylcholine released onto enteric neurons. I'm going to go over here to this guy. So acetylcholine gets released onto these postganglionic cholinergic enteric neurons. So essentially just neurons, enteric nervous system neurons that use acetylcholine as well as a neurotransmitter. So these guys will secrete acetylcholine, which will bind muscarinic receptors, and among other things, will bind these muscarinic receptors on parietal cells, and you'll get the release of histamine, on parietal cells. And then you'll get activation of that potassium pump, right? And so you'll get a more acidic environment. Acetylcholine will also inhibit somatostatin production, so inhibit the negative feedback loop. Okay, so that's acetylcholine's main activity. The somatostatin itself, somatostatin once again inhibits G cell function, so it inhibits gastrin secretion. So under normal circumstances, G cells, when they're activated, are going to make and secrete gastrin, which is going to stimulate parietal cells and stimulate activity of that proton pump to make a more acid environment. Under normal circumstances, acetylcholine then, once again, will inhibit somatostatin, so it's inhibiting the inhibitory effect of somatostatin. So if you get an acetylcholine antagonist, then that will actually reduce stomach acid by no longer inhibiting the inhibitory effect of somatostatin. And I'm not going to go over here to this other non-adrenergic, non-cholinergic postganglionic neuron. I'm going to leave that for now. This slide shows gastrin and somatostatin interactions. Once again, G cells, which is where gastrin is made. So G cells, when they're activated by, among other things, stretching of the gut. And here's the antrum right down here. This is where the G cells and T cells are. So you get things like the gut is stretched. G cells will release gastrin. Gastrin will bind CCK receptors on these enterochromatin-like cells and cause the release of histamine. Histamine will stimulate parietal cells by H2 receptor activation to activate that proton pump. Also, gastrin will bind receptors on the parietal cells themselves and also stimulate proton pump activity that way, all contributing to a more acidic environment in the gut. Right? When the gut gets to a certain level of acidity, so to, for the pH of 3, somatostatin cells in the antrum are stimulated, and somatostatin goes and inhibits gastrin secretion to keep the system in homeostasis. Okay. Does that make sense? Hopefully, you can walk yourself through that. You probably have a pretty good understanding of what goes on. This is just another slide showing essentially the same thing. I'm not going to walk through this one, but I have extra slides for you to go through if you want to, if you're studying this stuff. Like I said, I'm not going to go through that. But I will try and go through this one, trying to reinforce the point of how gastric acid secretion is stimulated. Okay, so once, and this slide's really busy, so bear with me here. I'm going to try and make it through this one. Okay, so once again, when there's a stimulus out there, like smell of food and that sort of thing, or it's 12 o'clock, your body is trained to become hungry at 12 o'clock, right? Among other things, acetylcholine will be released in the enteric nervous system, and that acetylcholine release is driven by acetylcholine release. It's coming essentially from the brain. So the acetylcholine will bind these M3 receptors on parietal cells, okay? And then that's going to activate a GQ protein. You're going to get increased, among other things, increased intracellular calcium, and that's going to increase the activity of that sodium-potassium, or sorry, the hydrogen-potassium pump. Acetylcholine also is going to bind these M3 receptors on these ECL cells, and that's going to cause the release of histamine. Gastrin does the same thing on these ECL cells. So both, and also gastrin. Oops. Okay. Yeah. My animation here got screwed up. Sorry. Okay. I'm going to go back up here. Acetylcholine binds M3 receptors on these ECL cells. It's going to cause the release of histamine. Histamine is then going to bind H2 receptors on the parietal cell. You're going to get an increase in cyclic AMP with your stimulating GS, and then so you're going to get increased activity of the sodium-potassium pump. Okay, then coming back to gastrin, gastrin binds these CCK receptors both on ECL cells and on parietal cells, and that will also stimulate a GQ, G protein increase, among other things, intracellular calcium, and that will activate this proton pump. Okay, to inhibit that, prostaglandin E2 will bind the EP receptors. That actually has an inhibitory effect on that. That couples to GI. Okay, so that all will affect the activity of that proton pump. So essentially, gastrin can stimulate the acid secretion, stimulate proton pump activity, both by its effects on ECL cells and on parietal cells, and acetylcholine is the same thing. Prostaglandin secretion will inhibit that. Okay. In terms of defenses against gastric acid, the main esophageal defense is in the lower esophageal sphincter, and essentially what that does is it keeps closed and keeps the contents of the gut from coming up the esophagus, prevents gastric acid reflux, which is a bad thing because it's corrosive in the esophagus and can cause remodeling of the esophagus and all kinds of problems. Okay. In terms of the stomach itself, the stomach protects itself by secretion of a gastric mucus layer. You get this gel-like surface coating the stomach, and that mucus is production is stimulated by prostaglandins. Particular prostaglandin E2 is really important. So once again, when you have drugs like NSAIDs that decrease prostaglandin production, that increases problems in your gut. You're not getting that protective mucus layer. Okay. Also, bicarbonate secretion from epithelial cells. That's also involved in neutralizing acid near mucosal cells, so neutralizing acid in the gut. So two big defenses: mucus, largely driven by prostaglandins, and then bicarbonate secretion. Next part of this lecture is going to go over the drugs for controlling gastric acid secretion. First up are proton pump inhibitors. So proton pump inhibitors suppress the actions of this gastric hydrogen potassium ATPase that's involved in creating an acidic environment. Again, it's located in those parietal cells of the gut. These proton pump inhibitors, they're the most potent gastric acid secretion inhibitors, and they can lower daily production of acid by 80 to 95%. And they're used to treat gastric and duodenal ulcers, GERD, and gastric acid hypersecretion. Proton pump inhibitors on the market include omeprazole, Prilosec, right? And then these other ones that I'm not even going to try to pronounce, but hopefully you guys are familiar with these, or you will be. Proton pump inhibitors, in terms of their mechanism of action, they're prodrugs, so they need to be activated in an acidic environment to be effective. Excuse me. And once they're absorbed, what they do is they diffuse into parietal cells of the stomach and accumulate in those canaliculi, and there they bind covalently with that proton pump and irreversibly inactivate the pump. And here's a test question, essentially. Proton pump inhibitors irreversibly inactivate that proton pump. And importantly, acid production is only going to resume when new pumps are synthesized and inserted into the luminal membrane. And that can take from 24 to 48 hours. Okay, so again, you're irreversibly blocking those pumps, inactivating those pumps, proton pump inhibitors. So this slide shows proton pump regulation. Essentially, I'm not going to go over that part again. Actually, I'm just going to point out right here, it shows proton pump inhibitors. They're going to, once again, bind to that proton pump and then stop its activity, and stop it producing acid, or making that acid environment in the gut. Okay, and those things, they're going to stay inactivated until they're metabolized and long gone. So stomach acid production is only going to kick back in to a large extent when you get new proton pumps are synthesized and inserted into the lumen. Proton pump inhibitors, they need to avoid degradation in the gastric lumen. So obviously you want them to get to where they're going, those parietal cells. And if there's a problem with that, there are a couple of these guys, pantoprazole and lansoprazole. Those guys can be given IV if necessary. And they come in different formulations, largely to help protect them long enough to get where they need to go to find that proton pump. So enteric-coated drugs, inside gelatin capsules, enteric-coated granules also get used. Enteric-coated tablets get used as well. And then you can use sodium, or the powdered drug combined with sodium bicarbonate to eliminate some of the acidity as well for those guys. So they need the stomach acid initially to be broke down into the active drug, but then too much and they're not going to be effective. Okay. A bit more about proton pump inhibitors agents in African Americans are more likely than others to exhibit slow metabolism of these proton pump inhibitors, and that's due to a genetic variation of the cytochrome P450, cytochrome P21C19. You don't need to memorize that, but you should realize that Asians and African Americans tend to exhibit a slower metabolism of proton pump inhibitors due to genetic variation, and that the slowed metabolism can contribute to an increased efficacy in these people. Also, increased toxicity. Okay, so for what little toxicity there is from these guys, which brings us to their adverse effects. And there aren't a lot of adverse effects. The most common are nausea, abdominal pain, constipation, flatulence, and diarrhea. So unpleasant, not necessarily life-threatening, but unpleasant enough. They also can interfere with metabolism of other drugs as they're metabolized by those liver cytochrome P450. Chronic treatment with omeprazole will decrease the absorption of vitamin B12, so that's something to be aware of. I actually always take that stuff, but every month or so I'll stop and take an H2 blocker just to switch up the mechanism of part because of what happens to vitamin B12. And importantly, rebound hypersecretion of gastric acid can occur upon discontinuation of these proton pump inhibitors. And that's nasty, I can tell you from personal experience, which is why when I take this stuff, I always switch up the proton pump inhibitors and the H2 blockers. Which brings us to the H2 blockers. Everybody still awake? I gotta. You are the most. I gotta quit saying that you're the most high class. You guys know that already. That might be a test question too. Okay. H2 antagonists also get used a lot for gastric acidity. Cimetidine. These are easier to pronounce, so they're better drugs. Cimetidine, ranitidine, famotidine, and nizatidine. Is that right? H2 antagonists are used, all but nizatidine to be given IV. What these guys do is they reversibly compete with histamine for H2 receptors on those parietal cells in the gut. Okay, so remember, those H2 receptors coupled with GS cause increased cyclic AMP, and increased cyclic AMP causes increased activity of proton pumps. These guys are going to competitively stop that. Okay, and here's another test question. These guys reduce basal acid secretion, not infused acid secretion. Okay, and you often need to do things like nighttime dosing for ulcers. So you'll still be able to induce acid secretion with these guys. So if you go to New Orleans and have it like the spiciest gumbo they have, you're still going to get increased stomach acidity with these things. Okay. These guys are, in terms of elimination, they're mostly eliminated by the kidneys. They get filtered out and secreted. They have, in terms of adverse reactions, these guys don't have a ton either. Although diarrhea, fatigue, drowsiness, muscular pain, headache, and constipation have all been reported with these guys. Also, very high long-term doses of cimetidine will reduce androgen receptor binding. Also, these really high doses can interfere with estradiol hydroxylation. So, for some reason, somebody's taking super high doses cimetidine, they might have these effective issues that you should be aware of. They also might inhibit the absorption and bioavailability of other H2 receptor antagonists. Tolerance and rebound is important to be aware of in terms of these acid-reducing drugs. As I said, I have personal experience with this. Tolerance can develop as early as 3 days, and tolerance can develop from, among other things, decreased sensitivity, which might be due to hypergastremia, stimulated histamine release from ECL cells. So basically what happens is you get a buildup of gastrin in the blood that causes this over-release of histamine, which then will drive increased stomach acid production. And also, so then you get that increased acid production, and then when you discontinue the H2 blocker or a proton pump inhibitor, once again, some will produce more gastric acid than you want it to. Okay, agents that enhance mucosal defenses. That's a nice little mouse here. Prostaglandin analogs get used to increase the ability of the gut, increase the defenses against stomach acid. So prostaglandin E2 and I2, they're the main prostaglandins synthesized in the gastric mucosa. And what they do is they, among other things, they find parietal cell CP3 receptors, which these receptors on the parietal cells of the GI. So they're going to inhibit activity of the proton pump by decreasing levels of intracellular cyclic AMP. Okay. And prostaglandin analogs also have cytoprotective effects by stimulating mucin and bicarbonate secretion, so and increasing mucosal blood flow. So and that was a question on the last test, right? Prostaglandin E2 can be used to treat ulcers and that sort of thing, among other things, by beefing up the defenses of the gut. So increasing the activity of the mucosa. Okay. Misoprostol, I don't know if I'm pronouncing right, is a synthetic analog of prostaglandin E2. That gets used to treat NSAID-induced mucosal injury, and it inhibits both basal and stimulated acid secretion. Okay. Adverse effects, one should probably be able to guess. Diarrhea, abdominal pain, and cramps can occur in up to 30% of patients. It can also exacerbate inflammatory bowel disease, get increased prostaglandin activity. Prostaglandins are involved in producing mucosa, but they're also involved in inflammation, that sort of thing. And they can also cause uterine contraction. So it's not a treatment you're going to use when somebody's pregnant. Okay. Cyclophate is another drug that gets used for stomach acid type disorders. What that does is it inhibits pepsin-mediated hydrolysis of mucosal proteins. Did you guys go over pepsin previously at all? I hope, maybe a little bit. Pepsin is involved in breaking down peptides, that sort of thing. Okay, so cyclophate actually inhibits that pepsin-mediated, once again, hydrolysis of proteins. And so what happens is that in an acidic environment, the cyclophate is converted to a viscous polymer that adheres to and protects epithelial cells, ulcers, and craters, so it will help the stomach as well. And so it's also hypothesized to have cytoprotective effects, and that it's thought to stimulate local prostaglandin synthesis. So a few different mechanisms for cyclophate. It also gets used for things like oral mucositis, bile reflux, gastrophy, radiation proctitis, which I've forgotten what that is, and then solitary rectal ulcers as well. So by causing that protective coating, it can be useful for other things as well. Okay, I forgot that cat was still in this thing. She does not look like that anymore. Back when she was cute. Yeah, 5 o'clock in the morning. Those warm days. Anybody else have a cat who's freaked out by the warm days and wants to go out at 5 in the morning? Okay, never mind. Antacids. We got to cover antacids in this lecture. Antacids, of course, get used. There's a more old school way of treating high gastric acid content. There's several to choose from. You can use sodium bicarbonate. So, although that can have problems because you can get increased alkali and sodium loads typically dangerous if somebody has kidney or heart problems. Calcium carbonate in antacids you use help neutralize acid and took in a combination of magnesium and aluminum, which are preferred by most people. And in terms of antacids, I'm not going to say a ton about them, but surfactant simethicone often gets added to antacids to help reduce the foaming and esophageal reflux that can go on with those guys. Because when you're neutralizing the acid, you're obviously going to have some other effects, including foaming that can happen. Some adverse effects, those people who all day long chew on antacids, probably doesn't happen as much anymore as it used to, or H2 blockers, etc. came out. The absorbed aluminum, using the aluminum magnesium combinations can contribute to osteoporosis, also encephalopathy and proximal myopathy. So you don't want to have too much aluminum absorbed, and take care with that. Hypercalcemia can cause problems in patients with uremia. So people are trying to get calcium from their antacids. And then also you can get what's called the milk alkali syndrome, where you get this alkalosis, hypercalcemia, and renal insufficiency that will occur with chronic ingestion of large quantities of calcium carbonate. Another problem that can happen, aluminum and magnesium can chelate other drugs in the GI tract, making them ineffective. And then antacids can interfere with a number of other drugs due to their alteration of gastric and urinary pH. So obviously some drugs, especially things like prodrugs, can be affected by gastric acid levels. So, and things like thyroid hormones, allopurinol and imidazole can all be affected if somebody's taking these antacids. So something not as quote unquote safe as you might think it would be. So other acid suppressants and cytoprotectants include muscarinic M1 receptor antagonists. Those guys can reduce basal acid production by 40-50%. They include pyrazine and olanzapine. M1 antagonists are, it's M3 receptors that are right there at the gut and the entire nervous system. The M1 antagonists are thought to work by their actions on intramural ganglia. So as we're coming down from the brain down to the entire nervous system. So they bind receptors on neurons in or near the stomach wall, but upstream of those M3 receptors on parietal cells. Okay, and the M1 receptors come to TQ. So when an M1 receptor is activated, that's going to then stimulate in these neurons surfoline secretion, which is then going to stimulate gut acid secretion. So if you're antagonizing that, with the M1 antagonist, then you're going to get reduced acid secretion. Okay, and then along these lines, ribamapine is used in some countries to treat ulcers. It's M1 receptor antagonist. It's also thought to increase prostaglandin synthesis in GI mucosa. Okay, another agent that gets used in Europe is carbinoxolone. It's used to treat ulcers. I don't think it's used in the U.S. Are you guys familiar with this at all? Probably not. Mechanism of action is not well understood, but someday in your lifetime, that stuff might show up on the U.S. shelves. And then bismuth compounds are sometimes used to treat ulcers, and they're prescribed with the antibiotics for H. pylori. You might notice I'm not covering antibiotics in this lecture for the H. pylori. Okay. We'll leave that for infectious disease. Okay, I'm going to finish up this lecture with acid peptic disorders and therapies. Just a couple of more specific disorders, including GERD. gastroesophageal reflux disorder. So in that disorder, you're probably familiar with it, stomach contents leak backwards from the stomach to the esophagus. It's very common in the U.S., where we do things like carry our coffee cup around all morning, stimulating stomach acid. It can cause severe erosive esophagitis. You really don't want this stuff. And as the disorder continues, the squamous epithelium is replaced by intestinal columnar epithelium. So you get what's called Barrett's metaplasia. So essentially, you get remodeling of the esophagus, and it becomes a different sort of tissue. It's not as flexible, etc. And also, you get an increased risk of carcinoma. So it's not very nice. Most symptoms, most GERD symptoms are from injury caused by the acid peptic content of the reflux coming up and destroying the esophageal lining. In terms of therapy for GERD, the therapy is to completely resolve symptoms. You really want to stop this stuff, and you want to allow the esophagus to heal. Proton pump inhibitors are more effective than H2 blockers, probably because you won't have the ability so much for induced stomach acid secretion. And then I didn't want to get too much into the clinical aspects, but there are guidelines for medical management, and good many Gilman slides at the end of the lecture. I included here. This is a super simple slide to show the esophageal disorders. With achalasia, there's reduced vagal tone. So I'm over here, and reduced vagal tone of the esophageal sphincter. So the esophageal sphincter will open up easier, and so among other things, you get acid reflux that can go on, stuff coming up. Okay, and that's obviously not good. Okay, peptic ulcer disease. Finish with that. It's an imbalance between the injurious and defense factors in the gut. Okay, and so once again, defense factors that we have against peptic ulcer disease include prostaglandins. The big ones are prostaglandins, bicarbonate, mucin. Also, to an extent, nitric oxide, peptides, and growth factors can be defense factors. The injurious factors are acid and pepsin. So if you don't have the right defenses in the gut, you're prone to peptic ulcer diseases. Okay, so patients with duodenal ulcers do tend to produce more acid than controls, especially at night. That's not always the case, but that's a common theme. And then the ulcers that people actually wind up getting are interactions between H. pylori infection and exogenous agents that can lead to that damage, and including, or in particular, really NSAIDs. And that infection is also hypothesized to disrupt the production of somatostatin from B cells in the gastric antrum. So you reduce with H. pylori infection, among other things, you get reduced gastrin secretion, or the ability of somatostatin to reduce gastrin secretion is inhibited, so you get increased gastrin secretion. It's important to know NSAIDs play a major causative role in the development of ulcers. They're associated with 60% of ulcers. NSAIDs, remember, inhibit COX-1 in the mucosa, and when that's happening in the mucosa, you'll get decreased cytoprotective prostaglandin production. Prostaglandins, which really got things like mucin, bicarbonate secretion. And once again, the important ones for in the gut cytoprotective prostaglandins are PGP2 and PGI. Proton pump inhibitors relieve ulcer symptoms faster than H2 antagonists in terms of treating ulcers. And then I've just put the clinical recommendations and treatment regimens once again at tables at the end of the lecture. A little bit more about H. pylori before I'm done. It's a gram-negative rod-associated bacteria. It's associated with gastritis, development of ulcers once again. Treatment for that in particular aims at elimination of that bacteria from the gut. And I also clinical recommendations once again at the end of this lecture. So I'm obviously not going to test on clinical recommendations, but if you want to look at them. And that's it. Peptic ulcer disease. I'll just go through this slide real quickly. Usually what happens is, these people will tend to have higher stomach acid secretion, once again, especially at night. But also defense mechanisms are broken down in terms of if somebody's taking things like NSAIDs, you're not going to have the nice protective lining in the gut. That'll be thinner, be less, so you can start getting these gastric ulcers with destruction of parts of the gut, like bleed, things like that. And that's that. Any questions or anything? Once again, perhaps a little bit more digestible. Maybe a sad term, but and